My name is Laura Michaels, and I'm an associate professor in the Division of Hematology and Oncology at the Medical College of Wisconsin in Milwaukee. Welcome to the third press briefing of the 61st Ashe annual meeting and exposition. This one is Medicine for All, addressing health disparities to improve treatment in blood diseases. Before we begin, I'd like to remind everyone to silence your phones and, if possible, turn off the shutter sounds of your camera. So the studies that you'll hear about today present a mixed picture of how demographics and socioeconomic status affect access to clinical trials and effective treatments in blood diseases. While some studies offer encouraging evidence that racial minorities and older patients are getting similar benefits from cancer treatments as other patient groups, other studies suggest that there's still significant work to be done. We have sizable gaps to bridge if we want to improve access to care and outcomes, and if we want to deliver some of our discoveries to patients who've been excluded traditionally from progress in healthcare. At Ashe, we feel strongly that taking an inclusive approach to medicine is not only the right thing to do for our patients, for our communities, but it's also an essential part of creating medicines that are truly targeted to unique patient populations. Each of these studies reveals important insights that support our goal of getting effective therapies to all patients, not just the ones for whom easy access to healthcare is a given. So several of today's studies also offer important information on the impacts of clinical trial inclusion criteria, which call into question exclusion criteria that may systematically exclude minorities or older individuals. Inclusiveness in clinical trials is a key element of Ashe's Ashe Research Collaborative Sickle Cell Disease Clinical Trials Network, which is launched late last year, where we're working to ensure the voice of the patient is present throughout the clinical trials process, from site selection to recruitment to even choosing which trials and how we design them. More information on the Ashe Research Collaborative is available at asheresearchcollaborative.org. So whether it's sickle cell disease or one of the many other hematologic conditions that are treated by our membership, one thing's certain: we cannot provide precision medicine or precision prevention unless the research we do includes all patients. And that's one of the most important reasons of making sure that access to clinical trials, access to novel drugs, is provided in a widespread and fair manner. So, about today's presenters. Lena Weinstone of the University of California, San Francisco Benioff Children's Hospital will present our first study. So this study looks at socioeconomic status as a key contributor to disparities among children with acute myeloid leukemia. So Dr. Weinstone and her colleagues analyzed nearly 1,500 clinical trial participants, which is a remarkable number for a pediatric myeloid population. And they found that children from poorer neighborhoods were 2.4 times more likely to die during treatment for acute myeloid leukemia than children from middle or high-income neighborhoods, despite the rigorous setting of clinical trials. This typically, clinical trials ensure consistent treatment to participants. So details in this abstract can be found in number 703. Dr. Abby Statler of the Cleveland Clinic will share results of a study that she presented in an oral presentation this morning. She will look at 1,000 patients with AML treated at the Cleveland Clinic. And that revealed that African Americans were more likely to have evidence of abnormal kidney function than whites. However, this didn't impact overall survival. The findings from this study have implications for the design of clinical trials where patients may be excluded from clinical trials on the basis of comorbidities that actually don't impact survival. So artificial or false exclusion criteria that we need to think about. And the details from this can be found in abstract number 381. Dr. Nilanjan Ghosh of the Levine Cancer Center will present results of a study that offers positive and actually contrasting views to what we previously thought from scientific literature that had suggested that racial minorities tend to have poorer outcome in lymphoma or other diseases. In this study, Dr. Ghosh and his colleagues found that non-Caucasian patients and Caucasian patients treated for diffuse large B-cell lymphoma, one of the most common non-Hodgkin's lymphoma, at a safety net cancer center, had similar rates of overall survival and progression-free survival, thanks to a patient navigator program that helped patients address logistical barriers and things that might compromise their cancer treatment. The results suggest that when diseases are really optimally managed and socioeconomic barriers are addressed, equal results are possible. Dr. Ghosh will elaborate more on these, and his abstract is number 425. Dr. Anita D'Souza of the Medical College of Wisconsin will be next. She's going to discuss findings of a new study that suggests that age should not be a barrier to aggressive cancer treatment, including autologous stem cell transplant. In this study, researchers show that auto stem cell transplant, which is where the donor cells come from the patient themselves rather than from an alternative donor, is safe and effective in older patients with multiple myeloma, and suggests that people can benefit from therapy that has traditionally not been offered to patients, for example, above the age of 70. Auto transplant is a form of therapy that's very effective for multiple myeloma and other plasma cell dyscrasias, and traditionally older adults have been excluded from clinical trials that study transplant because they have a greater number of health issues. These findings might change that. Her abstract is number 782. And finally, Dr. Carl Kilgore of Avalari Health will present the first real-world evidence of autologous anti-CD19 chimeric antigen receptor T-cell therapy, or what we always call CART therapy, using Medicare claims data since the FDA's approval in 2017. So in this analysis, Dr. Kilgore and his team found that CART therapy can be beneficial for a broad population of older patients, people that might not have been included in those clinical trials, those people with diffuse large B-cell lymphoma, including those with multiple comorbid or chronic conditions. In fact, patients spent less time in the hospital and had lower healthcare costs after CART therapy than they did in the months that preceded the treatment. We'll hear news on that from Dr. Kilgore's study, which is abstract number 793. So make sure we have plenty of time for questions. We'll ask you to hold everything until afterwards, and all the panelists have finished presenting, and then we'll open up